US in luminal cancer. I am going to speak on three topics: esophageal, gastric, and rectal cancer. Esophageal cancer, I will speak in detail because I cannot speak on all three topics: gastric cancer principles and rectal cancer a case. We are going to take first an overview of esophageal cancer, and we say it is the 8th most common cancer in the world. And then there are either adenocarcinoma 90% or squamous cell carcinoma. So the management depends on staging. So we must stage. But for staging, we must know the applied anatomy and lymphatic drainage of esophagus. And the esophagus is divided into 4 parts. One is cervical esophagus up to sternal notch. Then from sternal notch to the lower border, to the lower border of azygos vein. Then from lower border of azygos vein to lower border of inferior pulmonary vein. And from lower border of inferior pulmonary vein too. So these are the 4 landmarks: cervical esophagus, upper esophagus, mid esophagus, and lower esophagus. Why I am saying all these parts of esophagus? Because it is important to know which part of esophagus we are dealing with when we attempt to decide whether this is a localized cancer or whether this is advanced cancer. And because if it is a local cancer, the management is different and staging can change. The problem is today, there is a lot of chemoradiation going on and people are not relying so much on EUS staging or whatever. They just do the chemoradiation first and then they may talk of restaging. However, my job is to tell the role of EUS in esophageal cancer. And I want to explain a concept that whenever there is a cancer, it travels through compartments. And there are 3 compartments: neck, chest, and abdomen. And the chest is divided into a central and peripheral compartment. And ideally, if there is no spread, it will remain in one compartment. So esophageal cancer restricted to central compartment or going to neck compartment or going to abdominal compartment is a concept we should be clear about, because the lymph nodes are classified according to these compartments. And this is a detailed description of management where the lymph nodes lie and where the lymph nodes lie, though there is different labeling so far as American and Japanese classification is concerned. We must understand this lymphatic drainage. The lymphatic drainage is a question, and you can see from this figure that the lymph channels are single cell thick. When we go towards the submucosa, the lymph channels become larger and they pass from distant organ towards the thoracic duct, like this is the thoracic duct down there. And then they move progressively in submucosa to cranial or caudal direction. And this is a cranial cone and this is. So in submucosa, what happens? The travel of lymph is in both direction and the spread of metastasis is longitudinal. So once the malignancy spreads into submucosa, it spreads in a longitudinal direction before spreading outward. This is the emphasis on submucosal spread of cancer. So this is where this tumor spreads, and this CT scan showed this is tumor at 35 centimeters. There was no nodes were seen on CT. PET scan showed no activity outside. So the skip metastasis in nodes are common. And that is what I want to know. Say that there are paraesophageal lymph nodes. They are far away from the tumor in this case. Namely, there is a aorta, and then there are again skip metastasis in front of aorta. So submucosa can drain, and at some place, the tumor will decide to go outside into periesophageal node that lie on the surface. So it may go from submucosa, then to intermuscular plexus or to periesophageal node one by one, or it can directly go into periesophageal nodes. And these are the pathways. It can also go directly into the thoracic duct. There is no need for the lymph to go into nodes. It can go directly periesophageal lymph node, periesophageal plexus, different pathways, but eventually the lymph node had to drain upward into the thoracic duct, towards the thoracic duct, where the passage of lymph is only in a cranial direction and not. So it can join the bronchomediastinal trunk, the thoracic duct, or ultimately they drain into the junction of jugular vein and subclavian vein in the neck. And this is how the subcarinal nodes are placed, and this is how the thoracic duct drains. So the only difference when there is a cranial flow, that the right side flow is more than the left side flow in the mediastinal node. And upwards flow is more than the downwards flow, as we have explained, because downward flow is only in the submucosa, and the thoracic duct is carrying the flow mainly upward direction. So up and right is more than down and left, and that is the basic principle of the drainage of nodes in the mediastinal trunk, which are two. There is a right bronchomediastinal trunk as well as a left bronchomediastinal trunks, which opens up near separately from the thoracic duct into the junction into the jugular vein. So this is so much so, and then we come into the prostate. These are the lymph node, and this lymph node is near the superior vena cava, and this is called 4R lymph. So we have to take care that these are the lymph nodes draining in this direction, going into the bronchomediastinal trunk, going into the thoracic duct, and ultimately the lymphatic drainage had to. So when we have spent this much about the lymphatic drainage, we go on to show that we have to do the TNM staging of the cancer, and this is the general principle. Basically, I want to say if there is 1 to 2 lymph nodes, this is regional, 3 to 6, again regional lymph node, and N3 is 7 or more than regional lymph node. So the staging is done on the numbers of node, not on the location of the node, because that is the main difference in TNM staging of the cancer. So here is where we see that there is a thickness, there is a cancer, there is layer 1, 2, 3, 4 at the OG junction, and then we see that there is a node just outside the wall of the. So this is node just close to. So again, this is just diagram to show how there is T1, what is T1 tumor, what is T2, T3 tumor, and T4 tumor. So T1 tumor is only in the submucosa, where the submucosa is thinned out, where a T2 goes beyond into the muscularis propria. T3 goes outside the muscularis propria, and T4 goes into the mediastinum. So T4 is further divided into T4A and T4B, which we can assess to a reasonable extent by endoscopic ultrasound. But for this matter, one thing I would say for mediastinal invasion, the best, most important test is endoscopic ultrasound, because it has the ability to assess the mediastinal invasion. And here is where, again, I have shown a simple diagram, because this is the superior mediastinum, middle mediastinum, and the inferior mediastinum. And where are we seeing? Because we are seeing the structures from in the esophagus, all these structures are being seen. So these structures, mediastinum invasion is anteriorly into the tracheobronchial tree, pericardium, and cardiac chambers, posteriorly to the aorta, azygos vein, prevertebral fascia, spine, crux of diaphragm, and laterally pleura, lung, and the structures of lung hilum. So this is the mediastinal invasion. Generally, people take casually about this mediastinal invasion. No, which part of mediastinum is involved? That is what we must assess. So now coming to staging, T1, low sensitivity and specificity. US has got a low sensitivity and specificity. This is CT scan is esophagus, CT scan is useless, and it is only on endoscopy. But we must still do endoscopic ultrasound because it can give us an idea of early esophageal cancer. Generally, people are reluctant in esophagus to use early endoscopic ultrasound for evaluation of esophageal cancer. But T2, as soon as the tumor becomes T2, the sensitivity and specificity is high, and the overstaging may occur. This is an example where the tumor has gone beyond submucosa, and it is involving around 20 to 30% circumference of esophagus. There is no node, and this patient was referred for surgery. You can see that at this particular place, there is no submucosa. It is gone, thinning of submucosa and thickening of muscularis propria or irregularity of muscularis propria. So the submucosa is here. It is this muscularis mucosa. Submucosa has been eaten up. When you follow this, in this place, submucosa has been eaten up. So this is an esophageal lesion that you can say this is here, and this is the early esophageal cancer lesion. So we do upper GI endoscopy, we see abnormalities, we biopsy. In this case, a US showed a 9.1 into 5.5 centimeter FNAC confirmed adenocarcinoma. So there was no. So in this case, as I am showing, this is the case. And in this case, it was difficult to get the FNAC, the histology. And we did a US. And after US, a wall biopsy was able to, tangential wall biopsy was able to see. This is the example of tangential biopsy of the lesion we showed. So this happens less commonly, but T3, the sensitivity is higher, the specificity is low because understaging can occur in this case. So this is an example. Patient has got a T3 tumor. And in this case, when we see a T3 tumor, we are also seeing that the pleura is outside. We can see posteriorly the spine and the azygos vein. T4, the invasion, when it is mediastinal invasion, it is sensitivity and specificity high. If the tumor is traversable, then the specificity, not traversable, then the specificity reduces. In this case, the tumor was traversable, and we can say the aorta is involved, subcarinal artery is involved, the pleura is involved, pleura is displayed, and this is the tumor has invaded the aorta as well as the branch coming out of the aorta. In this case, the tumor is invaded anteriorly. It is gone anteriorly into the right atrium. It is invading the right atrium. And in this case, the tumor has invaded the bronchus. We can see the white shadow, which is related to the bronchus, the white. So the end staging of the cancer, the latest nodal staging says that the number of nodes are important, as I've already said, that 1 to 2 are regional lymph node, N2 is 3 to 6, and more than 7. So you must count the nodes. So you must count the node, and you must count also the characteristics of the node, because the subcarinal nodes are normal, and normal size of the node is important. So it is the irregular hypoechoic rounded nodes and the number of these irregular hypoechoic nodes which is important in assessment. So we have done esophageal cancer, we have assessed local staging, we have done mediastinal invasion staging, we have done regional staging of the local cancer, whether N1, N2, N3, and then we have done the non-regional staging, that is where the neck staging, mediastinal and abdominal ultrasound. So this is the general principle of assessment of staging of esophageal cancer. However, there is a classification, and then this is a classification, though it applies for lung cancer, but I am merely mentioning this diagram to show that there are, this classification lymph nodes have been classified, International Association of Study of Lung Cancer. So the esophageal cancers are also labeled similarly according to the American classification, and we are trying to say what are the nodes. 1R and 1 and supraclavicular, and then 2R and 2L, 4R, 4L are upper mediastinal, 5, 6 are in the outer pulmonary window, 7, 8, 9 are lower mediastinal, and 10 to 14 are inside the lung, or they are pulmonary lymph. So this is the different distribution of different nodes and different stations where to decide which lymph nodes are present. So the location probably is not important when we are assessing on EUS, but probably we have to, because upper esophageal cancer can have a lymph node in the abdomen, but generally, if there is periesophageal lymph node, tumor and node at the same place, rather than one lower down in abdomen, it will be better to say that the staging wise, this is less severe. So any staging of advanced esophageal cancer from cervical to celiac, regional, nevertheless, it is poor if the node is located in distal esophagus or EC junction. So concept is patient with one field, that is cervical lymph node, two field, cervical plus mediastinal plus abdominal lymph nodes. So all the three combination of lymph nodes, this is more dangerous. So location of lymph node, as I said, doesn't matter, make it significant difference. But still, when we are mentioning the location, we have to mention the field, whether they are in cervical field, mediastinal field, or abdominal field, which lymph node in cervical field, which lymph node in mediastinal, and which lymph node in the abdominal field. So the nodes in this node is seen above the arch of aorta and belong to 2L, and we were not sure whether this is a malignant node, and the FNAC was done. This is a lymph node which is just outside the upper esophagus, and this is 4R, and this is belong to 4R station. This is a wall tumor, this is a 4R tumor, and below is the azygos vein. So a thin caliber EBUS scope was used to assess this. This particular lymph node was missed by a CT scan. So when you're taking the tumor, for example, this may appear, somebody may say this is a T3 tumor or T4 tumor. This is because tumor is invaded, pleural invasion is present. But you should discordance because this is N2, because this tumor is T3, but there is a cluster of nodes. Two nodes are present. This is not a T4 tumor on CT. It is a T3 tumor with two nodes. So this changed the staging, and we are very particular. And you can see the outline of the staging. This is one lymph node, and this is another lymph node. So then the question sometimes is, it is above the arch of aorta, belonging to, so this is cervical field, this is the mediastinal field lymph node. So sometimes why we are doing so much investigation? Because mediastinal lymph node assessment is best possible by doing endoscopic ultrasound. And we have to also decide whether this lymph node is pathological or this lymph node is not pathological. So the M staging of advanced esophageal cancer does not end, because just by saying we can do T staging or N staging, we can proceed to do M staging also. And because this can spread to liver, lung, bone, adrenal glands, and adenocarcinomas most frequently metastasize to intra-abdominal sites. And metastasis from squamous cell carcinoma are usually intrathoracic. So this is an example of liver metastasis, which was missed by endoscopic, which was missed by CT scan, but EUS high frequency tissue harmonic imaging, 26 megahertz, picked up these metastases, and then FNAC was done. And this is quite common to find the adrenal metastasis in these cases of esophageal cancers when we do endoscopic ultrasound. So the role of EUS does not end here. We can use EUS for restaging. T1 and T2 cancers, there is no restaging. It is unreliable for post-radiotherapy, because after radiotherapy, over and understaging can happen. But the question is, attitude is you must do, and you must keep on doing, because this attitude can be helpful if you find a suspicious lesion. Suppose somebody had done a chemoradiotherapy and is specifically looking for, so these challenges will come more and more in future to all this, because as chemoradiation grows for esophageal cancers, we will be forced to do staging in a radiotherapy person. So specifically for nodal status in T3 station with or without nodes, so or also in T4 tumors, which are typically inoperable. So EUS will be required for restaging in these circumstances, not in T1, T2, but obviously in T3, T4, they want to know. So the restaging, they are done by assessment by PET scan, PET CT, but even this, and then EUS is for relapse. Because if there is a relapse, locoregional relapse, the sensitivity and specificity is very high. And post-resection, EUS surveillance can be of value. So not that I want to promote, not that I want to say that we must do EUS, but yes, if you have removed esophageal cancer and then the follow-up cancer, then in one of the cases, one of the protocols for follow-up could be every 6 months or 1 year follow-up to see if there is any recurrence of a node within the post after surgery. So this is recurrent carcinoma or not. So this was difficult to decide whether this is recurrent carcinoma or not. But so this is the tumor. But then we saw it. We do the US and we saw that the wall was thick. This wall is thickened up. There is flow within the wall. And then in this case, we could do FNAC of the wall. And this wall, this FNAC. So there is a thickening of wall because in the stomach, when the tumor is there, it is more or less defined, more or less. But there is some mucosal bulge. In this case, when there is recurrence of the tumor, it is very subtle, and after it is can be very difficult to decide. So how do we do EUS in esophageal cancer? First, we must review the endoscopic finding. We must see, okay, on endoscopy, this tumor is present from this place to this place, from this length to this length, this much circumference, and then we must review the same cancer on CT, and we must complete all investigations before deciding to do EUS. And we must ask why I am doing EUS. Is it for staging? It's for restaging? It is for relapse. I must select a EUS scope based on my endoscopic finding. Because if tumor has not been traversed by a gastroscope, then I will have to do limited staging by keeping the scope above the tumor. And then the follow-up. And then there's some case series are there before I make. So the length is, tumor is considered clinically important in staging, but when I'm describing, I need to describe that the tumor is seen on length from this to this place. It is not that I use a linear scope to assess the length. I know lower point, pull back, upper point, rotate, circumference, but more comfortable can be radial imaging and radial endoscopic ultrasound, but I calculate the everything. The question is, should endoscopy be performed before EUS by the same examiner? I would say yes, because you have to assess the same thing first by endoscopy, and then you have to carefully look whether the same thing collaborates well. In fact, if the circumstances allow, I will do a simultaneous examination proceeding from endoscopy to endoscopic ultrasound. So this is, as I said, circumferential involvement is there, then the tumor is non-traversable, and this is advanced tumor. And a slimmer scope, there have been use of slim scope given by Pentax supplied, which I have used in significant number of cases, and they had good resolution. But currently, all the scopes have a standard diameter of around 12.8 mm. In these cases, I sometimes use an endobronchial ultrasound scope, which has got a diameter of 7.8 mm to assess the staging. So then what is the second step? I've done an endoscopy, I've obtained a CT scan contrast, and then I will do mapping. Okay, I will do a local regional mapping on CT and make my mind, okay, what am I seeing? I make a map, I'm going to see a tumor from this place to this place, but then I want concordance. I want it to associate it with my US finding. Some of the people are so sure of their examination that they don't want to look at the CT before proceeding towards endoscopic ultrasound. So I will again look where is the tumor and then decide accordingly and then proceed with any staging and decide with what are the lymph nodes involved. So complete all CT imaging before US and then consider to add cervical lymph node, pelvis lymph node, and maybe pelvis, then I think if we are doing complete CT, it must go to mid-thigh to consider when. So should ES be performed before or after CT? That is a question. So in lung cancer, again, the same question has been asked, but generally I believe nowhere in the world US has been allowed to be used as a modality for evaluation or staging before CT, but this question is there. And I think it is a good question because you can do an EUS before CT also. But each test contributes to unique staging information and integrated capacity. It can be better for detecting metastatic site. tumor above carina require bronchoscopy, cervical tumor require laryngoscopy. And this is the list we have to complete when we are looking at esophageal cancer. And then we have to say, what does PAT say? What does US say? Do they say the same thing? Because we have to do concordance. And before providing this patient for directing this patient either for surgery or for chemoradiation, we have to decide what exactly is the status of this patient. So till now we have said that we must first review finding, then do classify based on finding, CT scan, complete all staging, and then identify the purpose of staging. Why I am doing it? I am doing it for diagnosis. Yes, it can be used for diagnosis sometime. Am I doing it for staging? Am I doing it for getting a pathological tissue and the type of tissue in nodes where I'm worried whether they are normal nodes, whether they are possible pathological nodes. And here is where the complexities increases, especially in a country like India, where there can be nodes outside, where there can be nodes which can be due to tuberculosis, where there can be association of malignancy with tuberculosis. So we have to characterize before giving the therapy, whether surgical or chemoradiation. What do we do about the status or assessment of this node? Because this is the purpose of EUS. We have to diagnose, we have to stage, and we have to get pathology. And then we have to select the probe. It is a mini probe, radial probe, linear probe, regular linear probe, slim linear probe, and which or a EBUS scope or a endobronchial ultrasound scope. So this is the selection is much easier, but as I said, probe depends on endoscopic finding and the diameter of lumen, and if normal, these various probes can be used. So this is an example where the radial probe was used and the tumor was assessed, circumferential tumor, the probe is assessed, the trachea is in the anterior, the mass on the right side, the aorta on the posterior side. So this is these images show verrucous carcinoma of the esophagus, which is relatively less common. And then this is the images show that this is what the CT scan has shown in these cases. Iodine mapping and CT scan images are there. And then this verrucous carcinoma. This is this is the lymph node found outside the verrucous carcinoma. And then this is the staging of the circumferential tumor. The scope selection depends on the diameter, as I said, slim scope, cinescope, EBUS scope, and EBUS scope. Previously, there was a suggestion that you must do dilatation of the esophagus, even if it causes perforation. But today, I would say this is not recommended to dilate and perforate and then proceed with the management. Don't dilate, don't land up in problem, because this patient is anyway going to go for either chemoradiation if it is a complete structure of that. So this is the last part of the follow-up. We have come, but we are going to do follow-up, we are going to do surgery, we are going to go histopathology, and we are going to ask the histopathology in tumor board meeting, what was the finding in histopathology, whether they collaborated with my EUS finding, whether my pathology finding collaborated with the CT finding, and then we have to follow up after surgery for EUS for lab. The only purpose in follow-up for chemoradiotherapy, if I can say, would be this chemoradiotherapy would be if I want to offer this chemoradiotherapy for FNAC of the lymph node. So this is now the entire presentation of how I would be doing a staging of esophageal cancer. So when do we do FNA? Confirmation of malignancy in inconclusive disease, improve the accuracy of any staging, because sometimes differentiate nodal metastasis from inflammatory node, during which primary tumor should not come in the pathway of the aspiration. So there is a trick. If it is an esophageal cancer, go to bronchus or go below it or above it. So those should not come in the pathway. Go to bronchus. And EUS can visualize the metastasis from left or adrenal gland or lobe of liver. This tumor could not be traversed by a slim scope that is seen, and then the esophageal wall of tumor is seen, and there is no involvement of azygos vein. There is no, because the azygos vein, the border of white azygos vein is very clearly seen. And this is again the tributaries of azygos vein are very clearly seen in this case. So this is no involvement, but there is a lymph node, subcarinal area. A smaller one there is no way of sampling EBUS guided FNAC. And we want, if the surgeon wanted the question or the radiotherapist wanted to question whether this patient with lymph node is going to offer chemoradiation, if they want a question, we are ready to answer it by going into the trachea and taking the FNAC. So this is an example of lymph node in the esophageal wall, and this is a wall lesion that is seen. So this T2 is a surgical PET CT showed a positive 4R node, bronchoscopy was normal, and EBUS FNA confirmed that in this case, this was a tubercular lymph node with caseating granuloma, and the node was removed at the time of surgery. Surgery was followed by ATT. So the node was removed because this was a surgical option, because this large lymph node was troubling. Does elastography help? Should we be doing it during EUS? If not, when? If no, why not? This is just an example that we do elastography. And as I said, when you are doing a staging, you do every node, everything stage. If the elastography shows inelastic blue tumor, you can select the node, but the modality of imaging on endoscopic ultrasound or EUS are B mode imaging, color mode imaging, pulse mode imaging, elastographic imaging, contrast imaging, and then you combine the information you want to give to the CT for that. So when you do follow-up, you compare CT and EUS information for concordance or discordance. The concordance is defined at 2 or 3 studies positive for nodal disease, and non-concordant is defined as only one positive. The question is, who is going to win, me or the CT scan person? Because ultimately, the judge is the histopathological report. We have to follow up. And as I said, I have tremendous emphasis, at least in surgical cases, to seek concordance. And this is concordance. So you congratulate yourself or you kick yourself, you are wrong. And you try to improve in subsequent imaging, because unless you try to improve, there is no way that you are going to provide better results. And one of the reasons that I will elaborate later, that this is important to improve upon yourself, to improve your staging if you are doing T2 staging. So these are some cases. T3 tumor with extension, separate frame, a rounded node is seen outside the fiscus, pleura was involved, and it was seen freely in real time. So this is another case, and these are some cases, but I will not probably go into these details, just showing that this is the tumor, there is a spine, and then this. And this is a tumor where this is involving the crux. The crux of diaphragm is separately seen between the liver and the crux. So the crux of diaphragm is separately seen. So we have to be able to see always what is the mediastinal invasion. So this is the T3 tumor, metastatic lymph node in lung, T3N1 tumor, and then there is a peritumoral node above azygos vein. Pleura is seen beyond the tumor. The distinction of different station can be difficult at CT, as the parietal pleura is easily seen, and this lymph node is in the central compartment. This is a lymph node, T2 tumor, non-pathological lymph node in the paraesophageal canal, and this is in the anterior-mediastinal. So detailed evaluation can be carried out for this lymph. Now coming to gastric cancer. There is skepticism about accuracy of EUS in gastric cancer, and this is 46% for T staging and 66% for N staging. But I have to say some things in say early gastric cancer. No, don't do it. There is no role of endoscopic ultrasound, but I would say yes, there is. And advanced gastric cancer, they don't refute. Everybody says, okay. But we do not accept whatever accuracy has been given in the literature as say 40%, 60%, and there is different inter-observer variation. We have to make attempts to improve the accuracy of T staging in gastric cancer, because gastric cancer, it is important, and we improve the accuracy. Gastric cancer, the number of surgical cases rapidly increase, It is important to be able to know whether this tumor is operable or not. So skepticism about indication, because US is operator dependent and the literature is there. Literature says differently. And when you are staging, endoscopy is the primary procedure in early gastric cancer, and US is always questionable. But I would say always combine white light endoscopy and always combine in stomach, always combine. I'm merely mentioning the principle. No, you cannot do it. Though the Japanese may be unhappy about it because they don't want to rely on US. But why? Because endoscopy, if you're going to decide this is a gastric cancer, you'll feel the surface. Then you are looking for deep submucosal infection, which is decided whether there is a nodule in the depression, where around the tumor there is a submucosal bulge, prominence, or whether there are folds, converging folds into the tumor, which is this. Now, you have done an endoscopy and you find a say maybe only a mucosal tumor, or you found a deep submucosal tumor. So you're trying to think, okay, what is it on endoscopy? You are trying to make, and you must do EUS at the same time, because then you will be better able to evaluate. I will show. Submucosal cancer is seen as narrowing of the third layer. And if it is musculus propria cancer is seen as disruption of third layer and thickening of fourth layer. Okay. So this figure shows that this is the epicenter of tumor. If it is less than 2 centimeter, it is esophageal cancer. If it is more than 2 centimeter, this is considered a gastric cancer. Now see, this is a tumor in this epicenter. This tumor is in the stomach. Now I am seeing it. This is irregular surface tumor. There is some sorts of submucosal bulge. But this same tumor, if I am going to do EUS, I will be able to do same case, a better assessment by radial or linear. So in gastric cancer, always combine white light endoscopy and EUS. And always see concordance, because you do upper GI, you do EUS, you do histology, and then you become better, even in your endoscopic findings and your. So if you're doing only endoscopic findings and histology, you're doing concordance of two things. But EUS is going to make you wiser in cases of early gastric cancer also, and you will probably give better outcome. So always combine white light with endoscopy. So as I said, question whatever may be, you do EUS in early cancer, gastric cancer, and of course you do. The combination improves the diagnostic accuracy of staging, and it has been shown that it has a better outcome. So that is the reason my argument concludes, says that is too much too. Though I can give data also, but then this time is not there to fit in. Then staging in locally advanced gastric cancer. We can do PET scan, CT scan, skull base to mid-thigh. We can do laparoscopy in addition. But before that, what we are going to do is going to do submucosal invasion, and we have to combine white light imaging with US. As in upper GI, we are going to do, sorry, this slide belongs to some early gastric cancer. I brought it here, but I'm going now to advanced gastric cancer. Advanced gastric cancer, again, the principle is T1, T2, T3 tumor, then N, this is the number of nodes, and then number of nodes, and also the location of node also becomes important in gastric cancer, and M is, of course, different types of metastasis. And this is the different nodal classification of gastric cancer, where the nodes are defined 1, 2, 3, 4, 5, 6, up to 6 are included in periesophageal group. And then 7 to 15 are again goes outside, and then around the vessels, and then they become retroperitoneal and entry. So the 1, 2, 3, 6, 1 to 6 are mainly perigastric, around the perigastric. Then they are along the vessels, and then 16A, 16A1, A2, B1, B2 are more distant outside retroperitoneal. This is an example of some lymph nodes of different stations as defined by the American gastric cancer classification of lymph node. This is lymph node 1 and 7 in the upper figure, and then this is lymph node 1711P station. This is aorta. You see the aorta, you see phrenic artery, celiac artery. You see left gastric artery, lymph node 3 along the left gastric, lymph node at 3 station 3, 11P along the splenic artery, 12P along the along the celiac artery, and then this is again lymph nodes in different station close to the hilum of the spleen, lymph node above the right renal artery in a retrocaval location, 16. Then 12P is anterior to in pia vena cava. 3B is perigastric lymph node. So these lymph nodes, again, this is a lymph node along the left gastric vein and above the pancreas, and this is a lymph node in the near close to the stomach wall belonging to the station 4 along the greater curvature. So we keep on finding the lymph nodes along the different stations, and then we go into this infracolic compartment of US where we start dissecting these lymph nodes. That these lymph nodes are in the peritoneal cavity, along the mesenteric vein, along the mesenteric artery, along the different part, along the middle colic artery, or along the tributaries of mesenteric vein, the first or second jejunal vein. The margin of renal artery becomes important, and then we look for renal vein, lower border of renal vein, a lymph node below it, or a lymph node above it, 16A2, 16B1, and more in the retro. These are the lymph nodes which indicate inoperability generally, so far as compartment. So this is the lymph node station of, again, changing compartment. Then this is coming into the abdominal cavity. This is a supradiaphragmatic lymph node. This is a lymph node close to the crux of diaphragm. And this is a lymph node close to right inferior pulmonary vein. This is a lymph node below right inferior pulmonary vein along the lower part of esophagus. The lymph node is spread. You have to be careful. It is boring, but this is important that you have to be able to see this supradiaphragmatic lymph node, posterior mediastinal lymph node, and then we start the proper T and N staging in an advanced gastric cancer. So when he came to gastric cancer, I divided gastric cancer into early gastric cancer. I divided gastric cancer into advanced gastric cancer. I gave my arguments and reason as to why we should do early gastric cancer staging and why we should do advanced gastric cancer staging. Now, as I said, because I cannot speak too much details about each cancer, even in rectal cancer, I think rectum has got a particular thing. It has got mesorectum, and the tumor goes. And rectum, when you remove a gastric cancer, we remove the ligaments along the gastric cancer. But along the rectum, there is a big, thick fascia all around, and the ligament of rectum is mesorectum. And we need to remove the entire mesorectum surrounding the rectum. So this is a rectal cancer case. 48-year-old man, adenocarcinoma, MRI showed no lymph node, PET scored no lymph. But US showed a mesorectal lymph node. So somebody thought that this lymph node was very close to the rectum wall and it is just a pseudopode of the tumor. And no, that was when the imaging was repeated. This node is distinct from the tumor, and so this presence of this lymph nodes are not normally present in the mesorectum. Lymph nodes can be normally present in subcarinal area. We have to define they can be triangular. This is a rounded lymph node, hypoechoic lymph node present in mesorectum, surrounded by whitish tissue. This is a metastatic lymph node, and there is almost no need to do a biopsy in this case, where the biopsy has shown adenocarcinoma, because this indicates metastasis. So PET may miss, MRI may miss, and this is sure enough. However, the surgeon requested an FNAC of this node, and which was done, and this FNAC showed this at the time. The FNAC of mesorectal lymph node showed adenocarcinoma, and the staging was changed, and this staging changed to neoadjuvant chemotherapy rather than surgery. When we see the NCCN guidelines of rectal cancer, I don't find easily the role of EUS in any way in the guidelines when they are mentioning guidelines in staging, clinical stage, and primary treatment. But as I said, we are there, endosonographers are there, and you have to do staging, restaging, as mentioned in the esophageal cancer. So coming to the final part of my talk, each modality complements the staging of luminal cancer. A multimodality approach is recommended. If it is your own relative, you want as many modalities to give you as much information before selecting the therapy. Overall, US is an excellent test in local regional staging. It can add information beyond CT. If comes to nodes, CT may not pick up sub-centimeter nodes, and some of the nodes we have shown are sub-centimeter nodes, which have been picked up by endoscopic ultrasound. So US can take somebody off the table. Some surgery can be avoided. And I would go on to say that no surgery can be done in luminal cancer without a proper US. If you are going to operate, then give me a chance. Give me a chance to give you more information about US staging. And nodal counting can help. Nodal compartmental division can help. Nodal sampling may be needed. And when you do nodal sampling, you must avoid tumor. So, summary is, if it is esophageal cancer, try to do it. It is difficult. Early gastric cancer, whatever they say, always do it because you will become wiser. Advanced gastric cancer, try to do it for proper nodal staging. And rectal cancer, never proceed without US. Thank you very much.